Hello and welcome to today's session on human milk oligosaccharides added to term infant formula, or more precisely, structures identical to human milk oligosaccharides added to term infant formulas. I will comment on it later on during my presentation. My name is Hania Szajewska. I'm the chair of the Department of Pediatrics at the Medical University of Warsaw, Poland. Human milk oligosaccharides, known for years, but discovered again. And you may ask yourself, what is behind current interest in HMO? Well, there are many factors, but I think that three are really important. First, advances in analysis of HMO, which allow much better to analyze HMOs than previously. Second, it's a progress in biotechnology, which nowadays allows to produce at least some HMOs to be added to infant formulas. And last but not least, two important organizations, EFSA, European Food Safety Authority, and FDA, Food and Drug Administration, independently confirmed the safety of 2FL, 2-fucosylactose, and LLNT, lacto-N-tetraose, when added alone or in combination to infant, follow-on, and young child formula. So what I would like to discuss in my presentation, I will talk about some basic facts about HMO and health-related effects of HMO present in breast milk. I will talk about structures identical to HMO in breast milk added to infant formulas. Finally, I will talk about challenges in conducting infant nutritional studies. Let me start with the first topic, just to remind you some basic fact about HMO. The third largest solid components following lactose and fat. There are at least 150, probably 200, maybe even more structurally different HMOs. They have very specific branching and linkages, which are extremely important for their function. On this slide, I summarize major HMOs in human milk. They are fucosylated with a fucose added in this basic structure added to lactose, sialylated with a sialic acid added, or non-fucosylated neutral HMOs. The most abundant HMOs in 80% of mother's milks, namely that of secretor donors, is 2-fucosylactose, 2FL. You will hear a lot about this human milk oligosaccharides during my presentation. HMOs have no nutritional value for the infant. Still, they have a number of functions, which I will not go into the detail. They support the infant's immune system. Examples just include prebiotic effect, antimicrobial, antiviral effects, which are covered in other presentations. What I would like to discuss in more detail are human cohort studies, which looked at specific HMOs, pooled HMOs, but especially specific HMOs in breast milk and health outcomes, which are listed on this slide. And let me go in more detail into specific HMOs and reduction of infection. And one of those infections is diarrhea caused by Campylobacter jejuni. There is a famous study, prospective cohort study from Mexico, published already some time ago in 93 mothers and infant fur, which were followed from birth to 2 years of life. And what has been nicely shown that if the mothers have high levels of fucosylated HMOs in their breast milk, that especially 2FL, 2-fucosylactose, it was associated with a lower risk of Campylobacter diarrhea and with severe diarrhea. So this is an important finding showing that specific HMOs play a role in protection against infant diarrhea. It's not only about bacterial pathogens or also viral infections, beautifully summarized in this review article. And there are a number of proposed mechanisms of action, how HMOs can prevent viral adhesion. So for any infection caused by viruses, what is needed is the attachment of virus to the glycan receptor on the surface of the epithelial cells. And the structure of this viral receptor is very similar to the structure of oligosaccharides, such as 2-fucosylactose. And if this HMO is present, it can adhere to the receptor on the surface of the virus and can prevent the attachment of this virus to to the receptor on the surface of the epithelial cell. So they serve as a decoy receptors, and therefore they prevent this initiation of the viral infection. And last but not least, specific HMO indirectly elicit changes in the receptor binding, again protecting against viral infection. This has been shown in preclinical studies, but also in clinical studies when it comes to viruses such as influenza, rotavirus, respiratory syncytial virus, human immunodeficiency virus, norovirus. All of the viruses have no protection with lactose. Does it matter for future? Yes. It's one of the way of thinking is that we can think about HMO-based antivirals. Another group of studies, cohort observational studies, relates to HMOs and allergies. And again, you can see that specific HMOs have been linked with reduced risk of allergies. The data are not consistent, however, some of them are showing this positive effect. And I call your attention to this study, which shows that high levels of 2-fucosylactose potentially reduces the risk of IgE allergy in C-section-born infants at high risk for allergy. And there are many of those human cohort studies linking specific HMOs in breast milk and health outcomes, not only infections, not only in allergy, but also in sepsis, necrotizing enterocolitis, growth and body composition, and neurodevelopment and cognition. All of these studies are showing association, and association studies do not prove causality. However, they are very important as first step to intervention strategies. So my summary number one for this part of my presentation is breast is best, for many reasons, but one of them are HMOs, which provide at least 150 to 200 reasons to breastfeed. However, not all infants can or will be breastfed, and if not, they deserve the best we have got to give them. And this brings me to the second part of my presentations on structures identical to HMO in breast milk added to infant formulas. So let me start with the terminology. Well, when it comes to these HMOs, which are added to infant formulas, there are various terms used, like human identical milk oligosaccharide, synthetic HMO, artificial HMO, HMOs analog. There is no consensus so far. So my proposal is to use the term structures identical to HMO in breast milk. And why I think it's so important, because I think it's really important to differentiate HMOs which are naturally occurring in human milk, in human breast milk, and those which are biotechnologically produced, which are identical to HMO in breast milk, however, not originating from breast milk. And therefore, at least for the purposes of this presentation, I propose the term structures identical to HMO in breast milk. But as I said, there is no agreement, no consensus, and perhaps other people will come with better terms. I mentioned that these structures are obtained through biotechnological methods. So what are these methods? These are chemical synthesis, chemoenzymatic synthesis, but most recently, probably most often used, are microbial metabolic engineering, and E. coli is one of the bacteria which is being used. Probably not the only one which will be used, but this is probably the most used at the moment. Of course, one can say the isolation from human milk is possible. However, for the large quantities, it's not possible. So biotechnological methods are being used. Here on this slide, you see the examples of the first two structures identical identical to HMO, which are manufactured and approved by EFSA and FDA. And these were 2FL, 2-fucosylactose, and LLNT, lacto-N-neotetraose. They are being added to infant formulas, and let me just now briefly talk about evidence from published randomized controlled trials on this infant formula supplemented with 2FL, with or without LLNT. And as you can see here, there are mainly studies in healthy infants, even if there is published study in children with cow's milk allergy. Intervention is usually infant formula supplemented with 1 or 2 of those of those structures identical to HMO in breast milk. And the outcomes, the primary outcomes, very often it's growth. And why it's growth? Let me talk about growth a little bit. Well, the general concept is that the infants receiving a new intervention should really show a similar pattern of growth to infants receiving an existing form of nutrition. An intervention is considered safe provided the average growth of study infants does not differ by more than half standard deviation compared to a reference or control group. And now let me show the result. There is evidence from both 2FL with or without LLNTs that there are infant formula supplemented with these structures identical to human milk oligosaccharides are safe, well tolerated, and support normal growth. And this is a result from the future studies, which looks at a combination of those two structures and show that weight, length, head circumference, BMI were very similar and in line with the WHO reference growth standards. So this was for infant formula supplemented with 2FL and with or without LLNT, which are safe and well tolerated and support normal growth. There are also studies on 2FL supplemented infant formula, which exhibit immune biomarkers similar to that of breastfed infants. Breastfed infants, you can see here, and these are two different formulas with two different levels of supplementations with 2FL. And various inflammatory immune responses were evaluated, and the specific signal of immune responses was similar to that of breastfed infant and 2FL formula-fed infants. There are also studies looking at infant formula supplemented with 2FL and LLNT when added to infant formulas, showing shift the gut microbiota closer to that of breastfed infants. And indeed, you can see that these infant formulas promoted bifidobacteria and reduced potentially pathogenic bacteria. And last but not least, the addition of 2FL and LLNT is associated with reduced morbidity and antibiotic use. In the next part of the presentation, I will talk about the secondary outcomes reported by parents. So caution is needed when interpreting the result, but the results are very important, and therefore I want to address them in more details. So these 2FL and LLNT added to infant formula resulted in lower incidence of bronchitis, reduced lower respiratory infection, reduce use of antibiotics, and reduce use of antipyretics, especially the reduced use of antibiotics. 31% is important. Not only in this study, it has been shown, also in children with cow's milk allergy, published as abstract only as far as I know, but also show reduced use of antibiotics. Why it's so important? Because of the overprescription of antibiotics. Recent study from the United States, 70 children in the study involving more than 14,000 participants, 70% of them received at least one antibiotic prescription during the first 2 years of life. And there are data from other parts of the world showing that this overprescription is an important issue. So if this is the only effect of adding 2FL, LLNT to infant formula, it's really something that is worth considering. Evidence which I showed you from published RCT relates mainly to one or two structures identical to HMOs. However, we know that no single ingredient will act as a magic bullet. And as a matter of fact, after 2FL, LLNT, a number of new structures identical to HMO became available, and they are listed on this slide. And not only that they are available, but this is published as of today only as an abstract, but will be presenting at the beginning of May and Pediatric Academic Societies Conference, which looks at the mix of this term infant formula supplemented with a mix of 5 human milk oligosaccharides, which are presented here. And the conclusion of this abstract is that infant formula supplemented with a diverse blend of 5 HMOs supports age-appropriate growth and soft stooling pattern, is safe again, and well tolerated. And one can really expect that this mix of the 5 structures identical to HMO can have some really good health benefit, because if you look at the effects of individual structures, are very like this. But we need to have to wait for the full paper to know all the details. So further trials are needed, and as a matter of fact, they are underway. When I was preparing for this lecture, I looked at the clinical trials go, and there are 13 studies found for interventional studies evaluating human milk oligosaccharides in children. Various outcomes were studies. They do not add to 13 because some of the studies are looking at 2 or 3 outcomes at the same time. But you can see that people are working on it. By the way, not only in children, but also in adults. So my summary number 2 for this part of my presentation is currently available infant formula supplemented with 2FL with or without LLNT support normal growth are safe and well tolerated. Further studies are needed, but functional benefits, please remember, reduced use of antibiotics are very likely. Further studies are needed. It's very easy to say, but there are challenges in conducting infant nutrition studies. And in the final part of my presentation, let me focus on it. Current approach to test safety and efficacy of novel nutritional intervention, including the addition of the structures identical to HMO, is a pharmaceutical style approach. So RCT is accepted as a preferred approach. What is optimal? Optimal with breastfeeding should be as a gold standard. So randomization to breastfed and formula-fed groups. But this optimal is not possible because we know that infants cannot be ethically randomized to be breastfed or formula-fed. So what we do have, we have this randomized comparison of infant formula supplemented with any novel modification, like this structure identical to HMO compared to unsupplemented formula. And very often we have a reference group of breastfed infants who follow the same protocol as far as possible, but without randomization. But there are many challenges. Study protocols often require that infants to be exclusively formula-fed to be eligible for randomization. But exclusive formula feeding from birth is challenging, and also we do have problems with the timing of approaching mother without jeopardizing breastfeeding, because really breastfeeding, I will repeat again, is best. We also see increasing rates of mixed feeding, so recruitment of exclusively formula-fed infants is even more challenging. And many organizations like ESPEGAN, but also a group of experts, are addressing and developing standard for study. This is one of the most recent published in JAMA Pediatrics, which tried to answer the question, what is the best way to ensure the validity of clinical trial of breast milk substitute while protecting trial participants? It's very much in line with the Consort statement, but includes criteria specific for clinical trials of breast milk substitutes. Number of research, a number of themes were addressed. One of them was study design and breastfeeding support. I already touched it briefly, but there are 2 types of studies: non-inferiority of equivalence trials to demonstrate adequate infant growth and tolerance of a new breast milk substitute. And when it comes to approach to breastfeeding, participating infants should be fully breast milk substitute fed, and the decision not to use breast milk should be firmly established prior to enrollment to the trial. But there are many challenges, which I told you earlier. Both are intention to treat and pre-specified per protocol analysis is needed. There are also pragmatic superiority trials to generate data to support the nutrition of health claim. Some infants are receiving breast milk at enrollment, but it's important to demonstrate adequate support for breastfeeding, and ITT analysis is needed. Another part of the document is on trial intervention, but I will just add one additional issue here. Zinc ingredient, I already mentioned it. No zinc ingredient will act as a magic bullet. So usually a combination of various, which makes, of course, difficult to identify which of those is responsible. If it's a mixture of many, which one of them is responsible for the positive effect. Study outcomes. The primary and secondary study outcomes should be clearly established a priori. and statistical power calculation for the primary outcome should be based on a clinically meaningful effect size. And before a study is carried out, it's important to define what is an important difference between groups. It's important to define this minimal clinically important difference, which may be different for us as physicians and different for patients or their parents. But this is probably the most important thing when designing the study. This minimal clinically important difference defines the smallest amounts an outcome must change to be meaningful to patients or to parents. Regurgitation, think of regurgitation. What is important for us as physicians? One regurgitation per day makes a difference. Or what is important for parents? They may be different. So minimally clinically important difference has to be established prior to the start of the study. And finally, study outcome. The endpoints used to measure each outcome should be valid, clinically relevant. The use of surrogate endpoints in place of clinical endpoints should be appropriately justified and interpreted. But there are some issues. There are very often differences in how outcomes are defined and measured, which make it difficult, sometimes impossible, to synthesize the results and apply them in a meaningful way. That's why it's important to have this core outcome set, which is an agreed standardized set of the most important core outcomes, which include both benefits and harm, which should be measured and reported as the minimum. Of course, other outcomes usually will be collected. And many groups, including some members of ESPGHAN, are working on this outcome set. But this is important because, and if you want to pull the data, for example, in the meta-analysis, the definition, the outcome should be really exactly the same and defined exactly the same. So my summary number 3 is conducting infant nutrition studies is challenging. However, high standards for studies need to be followed. I know that the audience are likely to remember only 3 things from presentation or speech. So let me summarize the 3 things to remember. First, specific HMOs found in breast milk may contribute to health outcomes later on, and establishing a link may lead to intervention strategies. And I showed you some of the link from human cohort studies. Currently available structures identical to HMO in breast milk when added to infant formulas are safe and well tolerated. Further studies are needed, but functional benefits are likely. Remember about this reduced use of antibiotics. If it's the only beneficial effect, it's really already an important finding. And finally, conducting infant nutrition studies is challenging. However, high standards need to be followed to trust the evidence. And I thank you very much for your attention.